Hello, Pastor Palmieri here, getting ready to do a demo assessment on my friend Susie here. She's one of our high fidelity mannequins that we'll be working with, and you'll get to meet her and hopefully 3 others on week 3 when we do clinical front loading. So I'm hoping to have like a little mini hospital hallway going for you to go through to see all the mannequin. Well, you won't probably see all of them, but you'll be able to see hopefully 4 if everything goes the way I have it planned. But I wanted to do a demo assessment. I'm going to still do one in person, but I wanted to do one for you that you can look at again and again and listen to and just, pull it up later. And if you need a little refresher or just want to watch it again. And so that's what I'm doing here today. And I'm working by myself. So bear with me while I'm got 2 different computers going up here, trying to keep myself organized so that it's a smooth assessment for you. So the first part, when you walk in the room, and that part I'm not going to get because I'm doing this by myself, but you're going to walk in and tell the patient who you are. It's a good script to use is good morning or good afternoon. I'm so-and-so, and I'm a nursing student at ICC, and I'll be working with you and your nurse today until 1 o'clock or whatever time it is. It's good to say that you're working with the patient's nurse, because that in their mind says, okay, this student isn't going to be just in here doing stuff to me without my nurse knowing. And so that's a good thing just to throw in there and let them know about how late you're going to be there working with them. Clean your hands in front of the patient, even if you just did it outside. It's good practice to do it in front of the patient. It builds trust, and trust is everything. When you first walk in, you can do like a little safety survey of the room. I don't have any IV fluids going on Susie today, but if you did, you would follow them, look, make sure they're running at the right rate at the pump, follow it all the way down to the patient, or you can start at the patient and work your way up too. Either way, and just make sure that it's running right, that this is in fact who you think she is. So there will be an ID band and you can check that. Any allergy bands, any limb alerts, anything like that. If she has oxygen, is it in her nose right? Is it running correctly at the flow meter? Any other tubes? If she has a Foley catheter, is it hanging below the level of the bladder? Are there any kinks in the tubing? And then you can just build some rapport by asking. Now be careful with these questions because you might open a can of worms. But you might say, how was breakfast? How did you sleep? Most people don't sleep well, and a lot of times they don't think the breakfast is very good either. So you might pick something different, but try to pick neutral topics and maybe start getting them talking about their family, because most people are happy to talk about their family. So that's a good place to start and build some rapport. Okay, and then once you've kind of done that, you can ask, are you having any pain today? And they may say no, not at all. They may say that you may expect them to have pain because you heard in report that they have pain. And so go ahead and ask the questions. What does it feel like? What would you rate it right now? If it's a new pain, you're going to ask a lot more questions because you might be the very first person uncovering a new symptom. Okay. Another thing that's can be confusing for students is, when do I need to ask the orientation questions, and when can I assume my patient is oriented? And that's one of the good things about having a short conversation with them, is you can gauge a little bit if they're with the program or not. Are they answering your questions? Are they saying things are appropriate? Or are they, you can gauge if they know where they're at and what's happening with the situation. But if you're ever unsure, you may have to say, now these questions might be a little funny to you, but I have to ask them. And then you can say, can you tell me your name? And you can verify that on the bracelet that that's correct. Ask the patient where he or she is today and what is she doing here? Is it morning, afternoon, or night, or evening? And I like that better than the time, because anybody can look at a time at the clock and say what time it is. But can they get a gauge for what's happening hospital rooms have windows, so they can tell if it's daylight or not. So I really like the morning, afternoon, or evening better, but you will develop what works for you and your patient population that you end up working with. Do you remember why you're here? Because you're going to come across patients that forget or maybe have dementia or Alzheimer's, and you might have to remind them of what happened. You might have to remind them over and over again sometimes, and just kindly and gently remind them again. If they get any of the orientation questions wrong, tell them the right answers, because you're reorienting the patient and trying to help her be in the moment and what's going on right now. Okay, some more questions you can ask right now. I like to ask questions and like chit chat first, but you can delay these until the abdominal assessment if you want. But I like to ask, are you having any trouble emptying your bladder? Now, if the patient has a Foley catheter, you don't even have to ask that. You can see how well it's draining. But if they are ambulatory or have bathroom privileges, you can ask how they're emptying their bladder. When was your last bowel movement? And was it typical? Any changes or that you might be concerned about? Was it, typical for you, or was there anything unusual about it? And then tell the patient what you're going to do, because you've kind of done subjective or objective. That was a lot of subjective stuff. So hopefully you got that right. I'm going to tell her that I'm going to do a head to toe assessment, and she's going to, in her mind, think, assessment, what's that mean? I'm just going to listen to your heart and lungs and your tummy and just check your feet and legs. That's another way you can say it. You might modify it if you have a little child too. If you're assessing a child, you might say, I'm going to listen to your heart. Have you ever heard your heart before? Do you want to hear it? And like, let the patient hear it too. Just clean your earbuds or your ear pieces. A little tutorial on your stethoscope. All right, this is my personal stethoscope. It's a Lippmann. Many of you probably have that, but there's lots of good stethoscopes out there, and it doesn't have to be the same kind that I have. It has a turning diaphragm and bell, and when you turn this, you can hear a little click sound. So that's how you know if it's correct. Okay. All right, and then something to know about your earpieces. Okay, see how they are pointed up. So when I put these in my ears, they're going to point towards my nose. And that's what I want, because it's going to get the sound directly into my ear canal where I can hear it better. And these are easy to move. You can just take this like so and just bend it, and they are movable. So you're not going to break it, and bend it so that it fits for you. Okay, so that's a little tidbit that maybe nobody told you before. If you're not hearing anything at all, it could be because it's facing the wrong way. So that's an easy fix. Okay. All right. So I told her I'm going to do an assessment on her and listen to her heart and lungs. And most patients will say, okay. And that's your cue that you can proceed. That's your implied consent. Okay. As I'm talking to her, I'm looking at her and noticing, does her mouth look dry? Does she have to keep wetting her lips? Is she articulating her words well? Is her face symmetrical? Does right and left match? Is there anything unusual? Is there kind of a droop to one side? So I'm actually doing a lot of assessing, noticing, as Linda Caputi would say, while I'm talking to the patient. And this will get easier the more you do it. Okay. All right. Ignore my phone. Tell the patient to breathe normally, and I'm going to go ahead and start her lung assessment. I'm sorry, her heart assessment. Now I'm going to drop down her gown and tell the patient, if you're going to do this, she does not have a snappy gown on up at the shoulders. If she did, this would be a lot easier. And she's kind of sticky because she's a mannequin. Her skin isn't real skin, so it kind of is sticky. And I'm going to try to keep her modest, okay, as much as I can. So I'm keeping her breast covered, but I have the part that I want to listen to exposed, okay? And it's just her and I bonded with her, I hope, and so she trusts me, okay? So the first part is going to be listening to the heart sounds. You can do this in any order, but this has been the order that I've done it for years and years, and it flows nice and I can get it done quickly. And so I'm sharing it with you, but you might modify it how you do it. And there's no right way. There's no right or wrong way. So you'll develop your own routine with your assessment. But I like to show you mine because it does flow quickly and easily, and I can get through everything. And I most of the time don't forget anything, but even experienced nurses will forget something and have to go back, and that's nothing for you to beat yourself up about. All right. Another thing I like to tell the patient is that I'm learning, well, not me, but you are learning. And so you might listen longer than a lot of the other people that have been listening to the patient. So they don't worry that something is wrong because you're, listening and what did I hear? The faces that you might make while you're listening could be alarming to the patient. Just so she knows that there's nothing to be concerned about and you're just taking a long listen to learn. All right, so I'm going to put my stethoscope on the diaphragm. So that's the bigger portion, okay? And I hope it's actually turned that way. Careful, don't blow your eardrums out. But it is, you can just touch it and tell if it makes a good noise. If not, just turn it to the other side and touch that side, but it's right. All right, there's 5 landmark locations that I'm going to listen to. And when I go to those, I'm just going to listen to a few beats and then move to the next spot and listen, and then move to the next. Okay, I've got these in my ears, but not really, because then I can't hear. I'll be yelling at you because I won't be able to hear myself as well. All right, so I'm gonna do spot 1, spot 2. Hopefully you can see what I'm doing. And then down a little. I got her breast out a little bit, but I'm trying to keep the other one covered. Okay, and I'm glad that I have a female mannequin today, because breast can be a challenge when you're listening to heart sounds and lung sounds. And because it's hard to hear through mostly fat tissue and glandular tissue for the breast. And so you might just not be able to hear as well on women. And that's just how it is. When you get to the 5th spot, a little tidbit, don't grab her breast like that, just kind of like lift it, or you could with the back of your hand, or you can ask her to lift it, or just say, I'm just gonna lift your breast a little, and then put your stethoscope underneath there. Okay, and this is where you're gonna listen to your apical pulse. So once you can hear it well, you're gonna count that. So I've got my 5 spots, 1, 2, 3, 4, 5, and I'm gonna stay right here for a minute and listen. If I hear an irregularity, I'm going to listen for a full minute. If it sounds nice and regular, there's no skipped beats or anything, no funky rhythm, I can do 30 seconds and multiply by 2. What am I listening for? I'm listening for lub dub, lub dub, lub dub. That's your S1 and S2 heart sounds. Okay. You should be able to hear them in all locations, but the intensity will vary depending on where you're at with your stethoscope. Notice if you hear any other sounds. Do you hear anything that sounds like a lub whoosh dub, lub whoosh dub? It's kind of hard to mock a murmur with my mouth, but if you hear anything, and you're going to have to get used to hearing normal lub dub first before you can tell that there's anything mixed in. But that's the beauty of all of you listening to each other, because presumably you're young and healthy still, and you don't have heart murmurs or gallops or anything. So you get very used to listening to normal, and so you'll know when something doesn't sound quite right. That's one of the beauties of listening to normal. It's good to listen to abnormal too, but mastering normal is the first step. Okay, there's your 5 spots. Okay, now I've still got my stethoscope in my ears, and I do all of my auscultating together, because it's less of this, taking this off, putting it back. It just makes everything kind of smooth and flow really nice. So now I'm going to tell her that I'm going to listen to her lungs, and I want to listen to her breathing. And so I'm going to ask her to take a deep breath, nice and slow, deep in and out, and I'm going to use her pace. So if she's breathing faster, I can move faster. You can tell her to slow down if she's going too fast, but you're going to go through, I like 6 spots. 6 spots will cover the lung fields. Hopefully you can see her. So I'm going to start up here, which would be here, okay, and then move down a little bit, okay, and then you're going to run into breasts. So you're not going to be able to hear that much. So after that, then you're going to shift over to here, okay, to get these side lung sounds. So I'll just, okay, Susie, take some deep breaths. I'm just going to listen to you breathe. And she's breathing. I have her on, as you can see by her blinking. Got that side. Okay, so I've listened to 6 fields and I feel like I've covered all areas of the anterior lung sounds. So I'm going to give her modesty back. And as long as I have my stethoscope in my ears, I'm going to slip down to her abdomen. To backtrack just a little bit, what am I listening for? Air movement. You can tell normal by listening to you. Just take your own stethoscope, go around everybody in your house, all your kids, have somebody over for dinner, listen to their lung sounds and just listen to everybody. And you'll hear most of the time they sound pretty much the same among everybody. Little kids might sound louder. They don't have as much sub-Q tissue. So they're actually a really good age group to practice on because everything is so amplified with them. So if you have access to kids legally, grab them and ask that they will let you listen and make it fun, like let them hear too and stuff. You can give them a reward for whatever, for letting you play with them a little bit. And then, so I just want to know, do I hear air moving in and out? And you should hear, it should just sound like, okay, just a good air sound going in and out. You shouldn't hear anything other than that. But when it's abnormal, that's when you're going to hear stuff. Do you hear a crackling sound? If you take your hair and roll it right by your ears, that's what crackles sound like. Just kind of roll it in your fingers by your ear. And they're just that soft. So you have to really be listening for crackles. And so you would want to know what kind of patient's going to have crackles. And that's the part that you're going to learn pretty soon. Or maybe you did already with Professor Knight. But your crackles mean moisture. And there shouldn't be moisture in your lungs, right? It should be just air moving in and out. So if there's crackles in there, you've got some moisture. And they may not be throughout the whole chest, but maybe I only hear them down here on one side. Maybe she's got pneumonia there. So maybe that's what you're hearing, right? So why only 6 spots, you ask? Because the patient is tired. Your patients in the hospital are sick, they're weak, they're not their normal self that they are when they're at home. And so even just sitting there taking 6 deep breaths for you could tire them out, especially if they have a pulmonary problem. And so I like to try to make it count and get those 6 spots in so that I don't tire them out. If you didn't get a good listen, then listen longer, but I'm just trying to get you to tailor your assessment to your patient so you can really make it count, so you don't tire them out so bad. Okay. Now, you know what? I'm not going to go straight to the abdomen after all. I'm going to go to the posterior lung sounds. And I think what I'll do is, bear with me, I think we'll turn her. Susie, I need to turn you to your side. So I'm not sure what's going to happen to all my electronics here while I do this. This is very informal, just trying to give you something to look at again if you ever need to. And what I'm going to do is turn her my way so you can see where I'm listening on her back. These are really hard side rails to turn. So let's go back this way. All right, Susie, I need you to turn on your side and face the wall by the phone. And she may be able to do this on her own, but you might have to help her. Okay, let's see how. Okay, good. This is good. Don't sit on the patient's bed. Okay, I'm going to sit on the patient's bed for a minute just so I can keep her turned while I'm listening. Bring the camera up here. Okay. All right, 6 spots again, because our patient might tire out quickly, especially if I have her turned on her side. If she's got a breathing problem, that might even make it harder for her to expand her lungs. And so I'm going to be as quick as I can, listen in my 6 spots. Again, just for air movement. So keep in mind that her scapula are here, and you're not going to hear as well over bone either. So I'm going to start in the middle up here between her 2 scapula. So spot 1 and 2. Okay. And then I'm going to go 3 and 4. And guess what? 5 and 6, I'm coming out to the sides because I want to capture these lateral lung fields out here to the side. Okay. While I have her on her side, this is your chance to take a quick look at her skin. Okay. Everything looks good. Her bottom too. Now Susie's mobile in bed. So if I see any redness, it's probably going to blanch and be fine. But if you had somebody that was at risk for skin breakdown, especially take an extra look at them, or if they're having some incontinence or anything that might break down their skin around their bottom. But you're looking for blanchable, non-blanchable redness. And what that means is if I find a red area, if I push on it and it does not whiten out, that's not a good sign. That's stage 1 pressure injury, which you haven't learned yet. But that's really not a good sign. And then we have to get on that immediately and start turning that patient and get them off of that area where the pressure is. Okay. Tell the patient why you're looking at their butt, so they don't think you're weird. I'm just checking to make sure you don't have any skin breakdown. And I'll say, nobody can really look at their own back. So it's nice to have somebody look at your back every now and then in case there's something that you don't know is there. Okay. All right, Susie, you can come on back to your back. I'll help her roll over. She kind of flops over because she's not really alive. All right, now I'm going to move back to my original post. Okay. Now I'm going to go to her abdomen. And I might raise my table up a little so you can see better. Or there we go. All right, so I'm going to expose her abdomen. And it's good that she's laying down. It just makes it flat so you can really check her. And I'm careful about not just throwing covers back. I like to only expose what I'm looking at right now. And that just is going to further build rapport between her and I. I'm not just letting her lay there naked. All right, you're going to bless the belly. Okay, so you're going to pretend like you're making a cross in her belly, with her belly button being the middle of the cross. Okay, and you want to listen in each of those 4 quadrants where you just blessed the belly. It doesn't matter where you start. As soon as you hear a gurgle, and you can listen to your own tummy, and you'll hear gurgles, especially if you just ate or you're getting hungry, whatever. That is the normal sound. So we don't say normal in nursing. We always say what the sound is that we heard. And so we heard a gurgle. So I'm just going to listen here. And I hear it right away. Get these out of my ears so I can hear without yelling. And then move to the next quadrant. And the next quadrant. And the next quadrant. Abnormal would be if you don't hear a gurgle. If you don't hear something right away, park your stethoscope till you do. And you have to listen for a long time to proclaim that there are no bowel sounds. So most of the time in my career, I don't believe I have ever documented absent bowel sounds. They've been very hypoactive before, but I don't believe I've ever documented absent, because you have to listen for 5 full minutes to say that. But I will qualify that with that I haven't taken care of a lot of patients with abdominal, like big abdominal surgeries. I've had lots of C-section patients and gynae hysterectomy patients, and there's not as much bowel manipulation with them. And so they probably will have good bowel sounds. But if you've got somebody that comes in and they think they might have a bowel obstruction, you might hear some different sounds. You might hear a lot of tinkling in one corner, just a real busy corner, and then a corner that doesn't have anything going on at all. And so you can sometimes pinpoint where that obstruction is just by listening. Okay, so I've listened to all 4 quadrants. I'm just going to give a light push and just be gentle. You don't have to do this hard. Okay, and I'm feeling to see, does this feel soft or is it firm? Like if you've ever been really full of gas before and your tummy's just really kind of bloated and tight feeling, and that's kind of a mildly distended abdomen. Sometimes they'll get so distended that the skin is shiny, like it's really stretching their skin out real shiny. That's really severe. But sometimes you'll feel just a little firmness. And watch your patient's face too. Do they grimace or anything? Are they guarding when you palpate, or does everything feel pretty normal? Ticklish. Sometimes people are a little ticklish. A way to get around that is to put and this is especially true with little children, you can put their hand, and she won't bend right, but you can put their hand under yours to feel the consistency. So you can still get the idea of how firm their abdomen is, but then that way they're feeling their own hand on their tummy and it doesn't tickle as bad. Just a little tidbit for you. Okay, now we're going to shift gears. Auscultation is complete. So now I can set my stethoscope off to the side or in my pocket. We don't recommend around your neck because somebody could choke you out with it, but is that likely? Probably not. But if you're working in an area where people are more agitated, then don't do that. All right. Certainly, it's probably just a good idea not to hang it around your neck anyway. All right. So I'm done with her tummy. So I'm going to cover her up. Put her blankets back. She can fix them better herself, but I'm going to show her that I care enough to put her gown back down. All right. Then we're going to check her capillary refill on her hands. And you don't have to do every finger. I'm just going to do 1 finger of each hand because I'm comparing right and left. I want to know, does the right match the left? Because that would give me some indication. Maybe the capillary refill is slow on this hand. And it could be because maybe she had a surgery on this arm or has a fracture. And so you might see some changes like that below that injury. Okay. But in Susie's case, her capillary refill is immediate. So I could say less than 3 seconds. Those are all normal ways to say normal cap refill without, you can't say normal, that's a bad word. But hers is immediate. So that part's normal. I can ask her to grip my fingers so I can see if her grips are equal bilaterally. Tidbit, give them just 2 fingers. Sometimes they want to crush you. And if you give them your whole hand, they'll squeeze really hard and it hurts and jams your ring between your fingers and stuff. So if you find that to be the case, 2 fingers will help. Just have them squeeze that. And plus with little children, if you're doing it with little children, they can get their little fingers around that a lot easier too. All right. Okay, Susie, I'm going to pull up your blankets down here. Now you can pull down or pull up, but I like to leave my patient covered as much as I can. So I'm going to go down here and pull up from the bottom. I'm going to shift my camera so you can see what I'm doing. Okay. So I'm just going to pull my blankets up from the bottom. Okay. I need to adjust a little. Nope, let's go down. Yeah, there we go. Okay. All right, so I've got Susie's feet out. Okay. I'm going to look at her legs. Do you see any edema? Okay, and she's looking good. There's nothing here. Sometimes patients will tell you, I feel like my legs are swollen today. They look at their legs every day, so they're going to know if something's unusual. And I listen to them because they know themselves better than I can ever dream to. But take a look. Does the color match right and left, or is this leg a lot darker, or is it does it have like some blotchiness to it? But this one looks okay. You can even look at hair growth on the legs. somebody who has had a lot of years of poor circulation, you might notice that they don't have a lot of hair growth down here on, and it could be unilateral, but I always compare right and left, see if everything looks normal. And same with ankles and feet, going all the way down. We'll check capillary refill on one toe of each foot. What if they have polish on? You can still look at refill on the skin, right next to the toe. It doesn't have to be the nail. You can do that with just with the skin, and you can check yourself and watch the blood flow right back into your capillaries. And that tells you about perfusion, which you'll learn about a little bit later. All right, let's see. No edema, no skin discoloration. They look about the same. Can she feel me touch? Can you feel me touch? Oh yeah, I can feel that. Okay. Okay, and then I can say that's all I have to do today for your assessment. That's it. Did you have any questions? She might ask what you were doing or what you were looking for. Go ahead and educate the patient. That's a good thing. The knowledge is power. So tell them everything if they want to know. Some people don't want to know anything. Now let's go back to me. And I'm not being a very good teacher telling you to lean over the bed, so don't do that. All right, so this is the end of my assessment portion. So I'm going to ask her if there's anything that she needs before I leave, but I'm not leaving forever. So I'm going to tell her that I'm coming back in a little while. Maybe I have some meds due, or maybe she wants her pain medicine as soon as she can have it again, which is at 10 o'clock. So I'll be back at 10 with your pills. And anything I can get for you before I leave? No, just bring my pills when I want them or when they're due, and make sure everything that she has is within her reach. The IV's not leaking anywhere. It's still running. Everything is draining, and she has everything she needs, and I can walk away and know that she's probably going to be okay. I just thought of something I didn't cover with the IV at the beginning. What are you looking for on your IV site? Okay, you're not going to really be doing anything with the IV yet, just looking at the site. So what you're looking at is where the cannula goes into the patient's skin. Okay, and look at that site around there, and it'll have a clear dressing on it called a tegaderm. And that is a good thing because it allows you to see the site, but still protect it with, have it be covered. And so you're looking for any redness, because that would be a signal that there's a little infection brewing or some inflammation brewing there. And so I'm looking for redness, swelling, okay, or any leakage or drainage around that site, okay? And look above the site too. When a site infiltrates, you'll see that it's not running into the vein anymore and going to the heart. It's actually running into the subcu tissue, and their arm will get really cold and swollen, and it hurts. And the patient will know something's not right. They'll put their light on and say, I don't know what's happening with my arm. And they may be mad. You can put a warm compress on it, but that IV's got to come out. So you would, at that point, for now in the program, you would go find your nurse and your instructor and tell them that you found a swollen IV site, and they'll probably take it out, or maybe teach you how to take it out and then put a new one in. I think that is everything. And I hope this video helps you. I wish somebody would have done something like this for us when I was in this program. I graduated from this program too, 27 years ago. And we didn't have to do that. We didn't have the things that we have today. And so I had to figure this out on my own. So hopefully I can help you make it quicker than I did anyway. So I hope you enjoy it, and we will see you at front loading.